Hello and welcome to today's webinar, The Role of Hospitals in Addressing Barriers to Care. I'm Caroline Gumpenberger and I'll be the moderator for the webinar presented by the National Healthcare for the Homeless Council. This is a 60-minute presentation with the last 10 minutes reserved for Q&A. There is a chat box below the presentation slides for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A select number of questions will be answered at the end of the presentation during the Q&A session. Remaining questions will be logged and provided to the presenters for written responses after the webinar. If you're having technical issues, you may also call the Council's office at 615-226-2292 for assistance. Please note that the presentation slides are also available for download in the Files pod next to the chat box. Our presenters today are Kevin Lindemood, President and CEO of Healthcare for the Homeless in Baltimore, Maryland, and Brooks-Ann McKinney, Director of Vulnerable Populations at Mission Hospital System in Asheville, North Carolina. The learning objectives for today's presentation are that attendees will be able to discuss the effects and importance of hospital discharge planning, describe differing definitions of homelessness among various entities, identify ways to collaborate with community agencies and to address barriers to care and create shared protocols, explain why population health education is important and how it can break down silos within a hospital system, and summarize hospital involvement with the community. And now we'll turn it over to Kevin. Hi everyone, apologies for the inconvenience. This is Caroline Gumpenberger again. We have lost Kevin Lindemood's audio for the time being, and while we look to restore it, we're going to move to Brooks-Ann's portion of the webinar. If we could move to Brooks-Ann's first slide. Brooks-Ann, we'll move it over to you.
Thank you. Hey everyone, it's Brooks-Ann McKinney again in Asheville, North Carolina, Mission Health System. And I specifically am talking about population health education in hospitals and the overall community relationships and language and how to collaborate. Just so you understand, I mentioned this a little bit last time, but for those that were not on the call, we do have 6 critical access hospitals, and the reason that that's important to know is that I do have to work with the community on a level that is also, it's hard sometimes to talk the talk and walk the walk, especially when I came from a nonprofit background with FQHCs and coming into a hospital system. So looking at population health in hospitals and education, I'm really focusing on the discharge planners, care management, physician education is very critical, just due to those are the ones that have the fire in the belly, that the ones that have to on a daily basis are the ones that come in contact sometimes with the most vulnerable patients. And doing population health overview with all the clinicians all the way up to physicians, it is a different language. However, you can have specific examples on local resources that address the social determinants of health. And an example here at Mission Health is that we are doing a orientation for all the new RNs coming on board, as well as social workers, really addressing those social determinants and saying why it's important that we do listen to our patients, but also look at a holistic model when it comes to addressing their needs. I think from historically, hospitals have not had to address the community needs, but now due to population health, social determinants, and also looking at population risk, it's very important that we address these things. And if you can have RNs that are coming on board that know that from the beginning, they know that that's what they need to have as a part of the patient care model and quality. And a lot of these things will line up together, especially with the pop health standards, with CMS looking at that, and also with prevention of readmissions. It's very important. So I think today, more than ever, you can align a lot of the homeless community agencies along with that, as well as having people come and reach, like PATH teams. If you have mental health teams to come in and see the patient, meet them one-on-one, and really prevent readmissions that way. And a lot of times that's when even the primary care at FQHCs or with permanent supportive housing, respite programs, a lot of times that discharge to those agencies will prevent a readmission, which goes into the CMS guidelines of avoiding readmissions and high cost. So looking at different departments, being in the hospital system for almost 6 years, there's been many silos, and they all speak a different language sometimes depending on the department. And it's important that you accommodate to the needs, but at the same time, understanding that we need to work as a team across departments to address the social determinants of health. If the departments work more together, then there's a team effort, and it lifts the burdens, especially for the most complex patients. For example, here we have the care managers, we have the mental health side of things as well, and then sometimes because of that, the mental health side will not work with the inpatient medical side, but because of the social determinants and addressing these needs together, we have seen more success, especially with reducing readmissions. And another example was looking at the coding. If you do and I spoke of this last time, but the ICD-10 coding, really with homelessness and the physician involvement can help with documenting disability, but also it allows on the back end to have that data to prove why it is a need, that you have relationships with the healthcare for the homeless sites or with the housing agencies in the community, because then you can show that this is how many patients that need housing that are daily in the hospital. And also an example is documenting on referrals and allowing access to care plans. If you have the HMIS, Homeless Management Information System, in your community, the use of that also allows more coordination of care on the outside. And what I've seen here in the last 2 years, the more that the physicians have gotten involved, especially with coding, and also with the care managers having used to the HMIS system, it's allowed more teamwork to say, hey, look, this patient that's coming in, he has a housing voucher waiting, and we can work with the care manager at the local agency to discharge him. And that's where you start showing the return on investment with helping these patients, but also it prevents readmission rates. And I've seen that it's great success, especially when you have someone that has been coming in the emergency room for 5 years, and once they get housing, what I've done is use them as an example of how the readmission rate did decrease, and also how much money it does save the hospital. So that's when you get more into the return on investment into community agencies. So with shared protocols, it's really important to have a point person in the hospital that can develop protocols and have access to the EMR, or if you have a health exchange network, that point person can make sure that things are updated. But it's very difficult because many agencies have different protocols. And so if one shelter is faith-based and they have different rules, and then you have one that's with a county shelter, or if you have wet beds, or it can get difficult to keep all these things sorted. But if you have a point person that the agencies can talk to, as well as the discharge planners or RNs can talk to, then that can be the sort of the mediator to figure out how we can come up with a solution. An example is that there's a shelter here that sometimes will not take anyone if they don't have an ID, but now I've convinced them that if we have discharge paperwork, from the hospital, that they can get that ID, or they can get the ID the next day. So it's really important to have someone like a champion that can be in the community. But if you do not have that, it's important that the case managers that do discharge do understand that there is different protocols for the shelters. But if they do get involved on the community level, then there can be some leverage with that. And so this is when you really get into the community collaboration and the importance of it. So in our community, we have what is called Code Purple when the weather is inclement. I'm not sure what is called in your communities, but I'm that point person, and I do have to make sure that the numbers in our system across the board are updated, especially when there is, we do have like things like wildfires here that really affected a lot of people that were camping out, that were coming into the emergency room, and we had to open more beds in the community. And so I'm sort of that person to make sure that everyone knows on the discharge side, but also when there is an issue with if someone takes a taxi cab to the shelter and it's really late, and that was after the time, a lot of times the shelter will call me and I'll try to figure out what's going on. So I end up being the mediator. So having that point person can advocate and address the issues and develop the relationships over time. It's important that this will help with discharge and avoid readmissions, but also it just allows there to be more communication. And the more that your discharge planners have that one-on-one conversations with even the shelters or with appointments to the HCH clinic, they will build up on that, and then that foundation will allow more coordination of care to go smoothly, which will avoid readmissions. So another model that we have an example here in our community was with the wet beds, or the non-medical detox beds. And we had to be very clear when they were called, just due to the terms and making sure, because the facility that works with us is a faith-based facility that historically would never have anyone that was intoxicated to come in their doors. But once we did sit down and we had a community stakeholder meeting with the shelter, the police department, hospital, and the county government, we came together and developed a protocol from the emergency room, and the referral was made to show that they are medically stable, and it's just one sheet of paper put in an envelope, and then the police department escorts them to the shelter, and then they have a shelter bed that night, and the next morning they are offered to go into treatment or into the program, and we've seen great success with that. So this is really groundbreaking, just due to a facility that was very dry and did not believe in looking at the harm reduction approach. But once they realized that this was a need in the community and that we could work together, it was very successful. So when it comes to hospital involvement in the community, there's many ways that historically hospitals have been involved, especially with sponsoring, with buildings, or it just depends sort of how large your hospital system is. But when it comes to the city and county government and local COCs, the Continuum of Care, if you do have a healthcare administrator or executive that can sit on those committees, but also someone that can advocate for those highest utilizers. If you have a frequent user system engagement group, FUSE group, any way that the hospital can get more involved on the community level can really help overall the cost for the community, but also prevent readmissions. The collaborative effort we've seen here locally in Asheville, not with just the wet beds, but also we have a permanent supportive housing model that went up a couple years ago, which had the same stakeholders involved, and now we have through 100% retention rate for 16 units of the highest utilizers of the jail and from the hospital. So the more that the hospital administrators, or it could be the head of care management, or if there's any community outreach workers, them working together with the city, the county, the housing authority, it really allows everyone to be on the same page, because if you can be on the same page, it's a win-win for both systems. So some other involvement examples, the point-in-time count is the federal count that they do for homelessness, like a census every year. And even though hospitals cannot be included because they are an institution under the definition of homelessness, they're not really counted. However, a lot of local COCs nationally still look at those numbers. And so the point-in-time involvement here started at 3 years ago, and we've had as high as 33 patients just in that 24-hour period that were included in our local data. So the more that you can show that these people may be in the hospital, that point in time for those 24 hours really can show the need of housing in the community. Also with permanent supportive housing projects, just supporting the data on readmissions and costs. If you have a local fuse group, or if you even have a community high utilizer group that meets at the hospital, the more that you guys could show how much the data on the cost avoidance can really show the need, and also it can prove over time the success of investment in permanent supportive housing projects. And that also can be an investment with your local FQHC or healthcare for the homeless site. You can look at pre-intervention before they went into the clinic and after. So the data that you have on the hospital side is so important because a lot of the community doesn't understand why these people keep coming in the emergency room, or why there's a lack of affordable housing. But when you can give real numbers and real data, it can really push the cause. Also, advocating for patients to have priority if they're highly vulnerable. The EMR may have details that a housing agency may need to prove the vulnerability. What I've found that, and of course this is after you have your release of info and HIPAA, making sure that that's accommodating to your meetings or to the communication you have with the agencies. I can advocate for a patient if on the vulnerability index, if I could see that their number is very low, that I do have proof from the medical or mental health side that can help push up that number so that they are higher on the list. I've really seen how successful that can be. Also, when a hospital is involved with these most vulnerable patients, sometimes they get in housing and it may not be the best fit for them, and the hospital or the doctors involved can come together, and they may need to go into a nursing facility or group home, and they may need extra support. And a lot of times you can help the housing agency with those decisions because they are very difficult, and it may be best for the patient to have 24-hour care. So really the advocating has been very, very successful here. Also with the FUSE, frequent user system engagement model, which you can look into, there's more research under the supportive housing model with CSH. However, that has been proven across nationally that the more that the hospital is involved with that engagement, there's higher success with getting them into housing, but also just for collaborating across the entire system. I think it's a great model to look into. Also, if you do have HMIS access with that, that can also help with success for the most vulnerable patients. And the last example I have is just having community groups that meet at the hospital. Even if it's frequent users, but also we've hosted more and more, even with NAMI, the National Alliance for Mental Illness, allowing them to have space at the hospital, or just working more together on events that focus on the most vulnerable patients in the community. I really feel like the hospital has a great opportunity with that, and the more that we all understand that we are working together, I think that we can really have a big change in a positive light. So we're going to go back to Kevin. We lost you, and I'll pass it over to you right now.
In the category of technology being great when it works, glad to be back with you all. I was just presenting and fighting with the slide progression, so sorry for those of you that were watching that and wondering why the slides kept going back and forth. We'll start with a couple of big picture frames, and then get in at a little more of a granular level. But when we step back and look at hospital discharge, particularly discharge that can be described as being inappropriate, I think there has been an evolution that has been happening and that will continue to happen. We have to realize that contemporary homelessness in the United States is only about 3.5 decades old. It reemerged in the late 70s and early 80s. And there were some hospitals, such as the founder of the Healthcare for the Homeless movement in New York at St. Vincent's, that have been doing work with vulnerable populations very well. And there's a lot of other hospitals that were rightly alarmed by what they were seeing and didn't initially have very good ways of responding. And so two images that really stand out in my mind took place 30 years apart. One in 1995 at Healthcare for the Homeless in Baltimore, where I was a caseworker. I remember very clearly a yellow cab pulling up in front of the clinic one day, a person being taken out of the cab, placed into a wheelchair, only wearing a hospital gown, nothing underneath, a central line still in the person's chest, with a note pinned to the hospital gown that said, "Please return our wheelchair," along with the number and address of the hospital in one of the counties surrounding Baltimore City. These types of images happened often during that period. Nationally, such images in places like Skid Row in LA often made national news and created much dialogue, and communities were experiencing this as well. I think what's happened over the last 30 years is far better response from local hospitals to the point that such examples are extremely rare. The second image I want to present to you, it took place in early January of this year, 2018, in Baltimore City. A hospital in the middle of downtown Baltimore, well known for being well integrated in the community, strong partners of ours. A woman left the hospital at about 12 o'clock at night or so in a hospital gown and was wandering very slowly to a bus stop. She had been taken out of the hospital by security guards, and someone sitting next to her took out his phone and started filming what was happening and posted it on Facebook, and it of course went viral, and everyone said that this hospital had inappropriately discharged a woman to the streets. Now, when you dig into that scenario, and it's something that the hospital itself is still doing, you find that the providers of care thought they had developed an adequate discharge plan, that something happened between the transfer of the person from the healthcare providers to the discharge planners, and then from that transfer, as the person went out the door, had an altercation with security guards, and one thing led to another. The president of the hospital, the very next day after this had gone viral, made a public apology and pledged to do better, there was an immediate acknowledgement that such a thing shouldn't happen. I think we are on this continuum from something that has, quote unquote, always happened to something that we all recognize shouldn't happen, to the aspirational goal of a time when something like this never happens. We also have to acknowledge that all of this is taking place in a broader public policy framework where investment in housing has declined dramatically. We're spending about 40% of what we spent on housing in the United States in 1979. Social safety nets are getting less generous and are declining. The gap between the very wealthy and the very poor is widening, and hospitals are grappling with these realities, and communities are grappling with these realities without sufficient resources. So we have to acknowledge that this is hard, right? At the same time that there's this growing understanding that health is more than seeing a doctor or more than what happens inside the hospital, that where you live has some bearing on what your health outcomes are going to be. At the same time that that's happening, there's continued disinvestment in housing support and social safety nets. There's very challenging fiscal environments at hospitals. This is particularly the case, Brooksanne and I were speaking earlier this afternoon, particularly the case in so-called non-expansion states, states that did not expand Medicaid versus those states that did expand Medicaid. And when you look at hospital reports in those two categories of states, expansion states are seeing tremendous reductions in uncompensated care. They have more resources to work with theoretically, while non-expansion states are facing extreme pressure. So I think we have to acknowledge that we've got overwhelmed systems, and by that I mean hospital systems, referring to overwhelmed systems, and by that I mean social services systems in communities. I remember talking to someone from the hospital after this event happened in January, and she was beside herself and said, what are we supposed to do? We're under pressure to ensure that this doesn't happen, but we just don't have sufficient resources, and try as I do, I can't find adequate placements for vulnerable people in the community. I think we also have to understand that homelessness and the definition of it is not as simple as it may appear. We all kind of talk about homelessness as if we're all saying the same thing, but there are competing federal definitions of homelessness. The Department of Housing and Urban Development, HUD, uses generally the narrowest of federal definitions. An individual or family is experiencing homelessness if they are sleeping on the streets, or in emergency or transitional shelter. There are some complicated exceptions where someone might still be included, but that's generally the definition. So the point-in-time count that most communities use, which is funded by HUD or required by HUD, uses that definition. So someone staying in an abandoned building, someone doubling up with friends, neighbors, and relatives, living in someone's basement, living in a car, living in a place that doesn't meet that HUD definition is not considered homeless by that definition. Department of Health and Human Services, the entity that funds healthcare for the homeless projects, uses a much broader definition that does include those doubling up, living transiently from place to place. The Department of Education uses a broad, some would argue even broader definition to identify students experiencing homelessness in school systems all over the country. And there are several more. There's at least 7 federal definitions. The big divide is between those that count those who are doubling up and those that do not. This makes it very difficult to integrate multiple funding sources or to participate with entities in the community from a hospital perspective, participate with entities that use a variety of different funding sources. So you could be talking about someone that you've identified as homeless with one definition and referring to a community partner that uses a much narrower definition and isn't going to accept the person because they don't meet their definition of homelessness. This makes it extremely challenging to adopt a shared community understanding when people are using different definitions. And generally, most organizations recognize that there's different definitions. They tend to try to go as broadly as they can. But sometimes it gets, because we're talking about distribution of resources, it can get downright hostile with groups using narrower definitions insisting that someone that is a family that's living in a basement doesn't meet the definition of homelessness. Similarly, it's very difficult to develop organizational understandings. I know across hospitals, I know within our own organization at Healthcare for the Homeless, many of our own staff are confused by the different messages that they're hearing from different programs that use different funding sources. Some people might, this particularly becomes a problem on intake, some people might have an assumption that if you're living in a place on someone's couch, you're not experiencing homelessness, while we might have another staff member that would argue vehemently that they are. This speaks in our own setting, and I think in hospital settings, to the need for training, the need for discussion forums, the need to ensure that funding sources don't limit an approach, but it ends up being far more complicated than it may appear. Hey, we're just talking about homelessness after all. Well, we're talking about 7 different competing definitions of that phenomenon. So what happens on the other side when a hospital discharges out into the community? And I will discuss various types of discharge and then what some of those unintended consequences are, as well as a positive example in each category of times when discharge has worked well. One with a simple discharge to a local Healthcare for the Homeless program. Giving someone a card and telling someone to go across the street to Healthcare for the Homeless may or may not actually mean that that person is going to go across the street and be seen at a Healthcare for the Homeless project. Giving someone a card and expecting them to go 2 miles away or 5 miles away to a Healthcare for the Homeless project may not result in an actual episode of care. Because, as I mentioned at the start, you've got a system looking for resources, a hospital trying to connect someone in the community, referring to what in many cases are overwhelmed services. What we have done with a couple of our local hospitals is work on arrangements with the emergency department and with the discharge planner where we've got appointments that are held. We went through a multi-year period where we actually had shared staff that would physically escort the person from one system to another and ensure that they actually got connected. Similarly, discharges to shelter or service systems. That woman that was discharged in early January in Baltimore actually had a referral to shelter. It was a piece of paper with an address on it. The challenge was that it was to a shelter where someone had to show up at 6 o'clock at night and stand in line in order to get in. A phone call hadn't been placed to the shelter, so no one was expecting the person on the other end. And so that is often an example of a discharge to a shelter that's just not going to be effective, essentially akin to a yellow cab showing up in front of Healthcare for the Homeless with no previous arrangement having been made. And yet there are strong emerging models, and Roxanne talked about some of them, where hospitals and shelter systems collaborate together to ensure that there are sufficient places for people to go. But again, there aren't always sufficient places for people to go, and we'll talk later how that might lead toward some other interventions. There are examples of referrals to housing authorities where there are 8-year waiting lists for housing assistance, discharges to someone's home that may or may not actually be someone's home. This goes to the doubled up population, discharging to a place where the person says they're staying, which may or may not actually be the place that they're staying. The use of community resource guides often complicates this process. I was speaking with one of our social work collaborators at a local hospital just about 2 months ago, and she said, well, we've got these resource guides that we use, and this tells us where we can refer people in Baltimore, and we took a look at the resource guide, and it was about 5 years old, and several of the resources there no longer were in operation. And so what we did is we talked to them about connecting them to the local United Way, which has what's called a 211 system. You may have this in your community as well, where that resource guide is electronic. There's a telephonic access. It's updated in real time when community resources change, and it's something that's scalable instead of something that's outdated the moment that it's printed and distributed to a discharge planner or to a social work department. This really all comes down to this question: who are your patients? We in the healthcare space, I think, have been evolving toward an understanding of whole person care. And so this pie chart here on the left-hand side, and I see that my slide here kind of got complicated. But on the left-hand side under whole person care, this is actually supposed to be medical care, mental health services, addiction treatment, life skills, health education, and case management. So it's this recognition that multiple services are required to wrap around the person and treat the whole person at the same time. Look at the pie chart on the right-hand side. Who is the whole person when they're in the hospital? Hospitals generally are seeing a very small slice of that person's life. When someone's in the hospital itself or when someone's in the emergency department. And the rest of that pie, there's so much else that happens out into the community that really isn't sufficiently known when you're only seeing that person for a very small percentage of their time. I think increasingly hospitals are asking questions about who that person is and what the rest of their life looks like. And that goes to the need for a series of assessments to really address community-level barriers to care. What's the person's residential status? We spoke a little bit in the last webinar about assessing homelessness status upon intake every single time, and that being something that changes every single time someone's in the hospital. They might be experiencing homelessness, they might not. They might be living in one place, they might be living someplace completely differently next time you see them. Assessing their insurance status, and many hospitals, like many community health providers, have invested in staff that assess this at every visit and ensure that someone is insured before they provide treatment and before they refer elsewhere into the community. Accessibility and location of care. This is particularly important to assess when referring someone out of the hospital to a community-based provider or to a social service agency. Where does that take place? Where is that located relative to where the person's living, and can they possibly get there? It's kind of like the difference between having an insurance card and having true access to care. Referrals are very similar. A referral isn't going to actually happen unless those barriers are overcome and the person can actually get to the place of that referral. The capacity for a care plan, and I call this the 3 Fs for food, fashion, and pharmacy. A little bit of a joke there, the last being a PH. If someone has a plan to take a certain kind of medication, do they have access to the food that they need? This is really an important assessment. Do they have access to the clothing that they need if they've got a cast on their leg and need something to go around it? Do they have access to the pharmaceuticals that they need to actually address that treatment? This is one of the reasons, these 3 F's, if you will, along with residential stability, that the emergence of convalescent care or respite care models have been so important for hospitals. I think hospitals have realized and community providers have realized that there just aren't sufficient places for people that need to recuperate, who otherwise would do that at home, that have no home to go to, and need some kind of setting where they're getting more intensive care, where they're getting access to appropriate meals, to appropriate clothing, to appropriate medications. And that's really, I think, where there's not, for an individual or family experiencing homelessness, there's simply not enough resources in the community for that outside of something like a convalescent care program. And then a key barrier is transportation. Often bus tokens are the transportation method of note. We have found increasingly that giving someone bus tokens, particularly giving a family bus tokens, is probably not going to result in them actually getting there. And so we've been experimenting in our own models of care with not only cabs, but increasingly Uber and Lyft. And that's been incredibly important in getting families access to care. We did some research on this and found that when left to their own devices or when only given bus tokens, there was an extremely high level of no-show. And when we began investing in the modest price of a cab or a Lyft or an Uber, them actually showing up for an appointment increased dramatically, and it's something that we use almost universally in our pediatric and adolescent program now. So who are your community partners? Brooksanne talked about some of them. Community-based clinics, behavioral health clinics and programs, continuums, or is it continua of care, local health departments and housing authorities, United Way organizations, as I mentioned, that are increasingly weighing into the system-wide social service space. Out of those collaborations can come wonderful partnerships that speak initially to immediate access to care and services, but out of those conversations come the kind of higher level collaborations that involve convalescent care, discharge, emergency department diversion initiatives, and even permanent supportive housing that is being seen around the country to be very effective in improving health and lowering healthcare costs. Fundamentally, we're trying to seek system change. We're all facing understandably overwhelming pressure. And we have opportunities, I think, and particularly an opportunity that the Trinity system has embraced to strengthen systems. Sometimes that means whenever we want to do something new, not doing the things that we've done in the past. I think there are wonderful opportunities to contemplate the collective use of things like community benefit dollars that may have been used in certain ways in the past, that if pooled together could fund, as we're seeing in some communities, the construction of new supportive housing services geared toward high-cost emergency department users who are experiencing homelessness, that could result in system-wide convalescent care programs or hospital discharge programs that ensure that people have safe and stable places to go after a hospitalization or an ER visit. We really have to think about training and scalability. Having a single discharge planner that's using that paper resource binder is not something that's scalable. And having a system of staff that are well-trained where it is in the lifeblood of the hospital system is a way to really take those interventions to scale. And I can't end without noting the importance of public policy advocacy. Through associations, hospital associations can be powerful bodies, and making sure that that advocacy is taking place on local, state, and federal levels. If we want to end homelessness and improve health, we have to invest in access to health care, in housing, in stronger social safety nets, or else we're going to continue to be an overwhelmed system, referring to an overwhelmed system. And with that, let us see if there are questions.
Great. Thank you so much, Roxanne and Kevin, for your presentations. And for our attendees, thank you for attending today and for your patience and staying with us as we resolve the technical issues. Our apologies about that. Okay, seeing no questions have been entered in, we'd just like to take this moment again to thank our presenters and our attendees. The presentation slides are available for download. As noted at the beginning of the webinar, they're available for download in the Files pod next to your chat box. The slides and a link to the archived webinar will also be sent to attendees within 3 business days of today's presentation. An evaluation survey will present in your browsers as well at the close of the webinar. And we very much appreciate your time today. This webinar is now closed.